Dear colleagues, welcome to the conference of young scientists and interns with international participation, Multicolored Time Winter Session 2022. The conference is held by the state institution, the Filatov Institute of Eye Diseases and Tissue Therapy of National Academy of Medical Science of Ukraine and partners from Moldova, a medical university and pharmacy. So let's start. Our first speaker, Victoria Kolesnichenko.
Hello everyone. Let me present a clinical case of rare phenomenon in the specific treatment of the infection process. Namely, it's a clinical case of paradoxical response to adequate anti-tuberculosis therapy in the treatment of the tuberculosis panavitis. In 1995, an epidemic of tuberculosis infections was known in the Ukraine. This status is still maintained. Of course, the situation is improved after the increase in the level of treatment of the doctors and the discovery of new methods of the diagnosis and treatment. But fact is remain. Most attention is paid to a pulmonary form of tuberculosis, but we must not forget about other forms. You can see them on the slide, along with their frequency. We as ophthalmologists are interested in the ocular form of tuberculosis. It's a really rare form. This type of tuberculosis can be different types of uveitis. The main clinical manifestation and also presented on the slide. Please draw attention. In 76% of cases, patients have no pathological changes in the lung or pulmonary lymphatic system. Tuberculosis uveitis is a rare condition caused by mycobacteria of tuberculosis. Involvement of oval tract is the most common manifestation of the disease. The main symptoms are granulomatosis anterior uveitis, disseminated choroiditis, or focal in some cases, parsplanitis or intermediate uveitis, cystic macular edema, and systemic signs and symptoms of the infection may be absent and is performed by excluding other causes of uveitis. What about diagnostic? For today, its clinical symptoms is consist with possible intraocular tuberculosis without any other causes of uveitis. Positive response to ex-uvantibus anti-tuberculosis therapy, quantiferon test, CT-lung as a screening method, because as we remember 2 slides ago, I was taught about that in 2/3 cases patients don't have any changes in the lungs or pulmonary lymphatic system. And laser photometry is the most objective method of therapy evaluation. It's not only about tuberculosis uveitis, but another types of uveitis too. Quantiferon test. It's a complex, combined serological test. It's an US test. Advances of quantiferon test is absent of contraindications or adverse reaction, security to conduct, absence of false positive or during BCG vaccination, after BCG vaccination. Interpretation of the result less subjective than SCID tuberculin test. But there are always nuances. Therefore, if the quantiferon test was positive, it confirms the diagnosis of extrapulmonary tuberculosis. But if when quantiferon test is not is negative, this does not mean that we had to exclude the extrapulmonary tuberculosis. So yes, but no, it's not no. The phenomenon of paradoxical reaction to anti-tuberculosis therapy is the deterioration of patient's condition and appearance a new foci of inflammation against the without background the adequate tuberculosis treatment. More often, such a reaction occurs in patients with a severe autoallergy by the mycobacteria of tuberculosis, or in the patient with the severe immunodepression. The mechanism of reaction is presented on the slide, but now it's just a hypothesis. That means that need more future researchers. Fun fact. The same reaction with the same mechanism was discovered in the adequate treatment of syphilis. I don't know what you need to do with this information. Okay, so about the case. Patient T, 37 years old, she arrived to the Institute with the complaints of the significant disease decreases of vision and fog in the front of her left eye. 2 weeks ago, she arrived to the Institute at home city, was diagnosed anterior and intermediate uveitis with no cases of, etiology of the uveitis. At home city was intravitreal injection of the prolonged dexamethasone drug. We all know how its drug's name, but I don't want to say it. After intravitreal injection of glucocorticosteroids, she's state was performed with improvement, but after this, significant worsening. At the Institute, visus of left eye was 10%. According to the objective examination, the previous diagnosis was the panuveitis of the left eye, maybe tuberculosis etiology. A course of the systemic anti-tuberculosis therapy is prescribed with bettering of the state. A month later, she reported about worsening, decreases vision of the left eye to the 5%, exacerbation of intermediate uveitis. It considered as a phenomenon of paradoxical reaction to the adequate anti-tuberculosis treatment. Methylprednisolone 60 mg per day was prescribed, and condition of patient was bettered very fast. The patient was discharged with a visus of 50% on the left eye on the anti-tuberculosis therapy and 60 mg prednisolone with the tapering of shadow. A month later, in the follow-up examination, visus of the left eye was the 60%, anterior uveitis in the remission, intermediate uveitis is the sub-remission, less floating still have. And fundus as well, visualization, a massive chororetinal focus with scarring and pigmentation. The patient continued to take only systemic anti-tuberculosis therapy with no methylprednisolone. This case illustrated how important to know about paradoxical reaction to the adequate anti-tuberculosis therapy or antisyphilitic therapy, and we need to understand what cases really need intravitreal injection of prolonged glucocorticosteroid and what cases does not. Thank you for your attention.
Waiting for our partners from Moldova. Let's start.
Hello, dear colleagues. The topic of my presentation will be focused on the efficiency of orthokeratology in stopping the progression of uncomplicated acquired myopia during the COVID-19 pandemic. According to the National Agency for Blindness Prevention, the incidence of myopia worldwide in 2050 will affect up to 50.2% of the world's population, of which mild myopia will be 40% and moderate myopia 9.8%. Infection control measures imposed during the COVID-19 pandemic, one of the worst epidemic diseases in the history, have accelerated the adoption of the digital technologies worldwide. According to UNESCO, approximately 1.37 billion students and more than 130 countries globally are at risk of progression myopia due to digital life or e-learning replacing face-to-face learning in the classrooms. As a prolonged battle against COVID-19 is predicted, there is a real concern that the COVID-19 pandemic can insidiously exacerbate the myopia epidemic. The aim of the study was assessing the efficiency of orthokeratology in the COVID-19 pandemic period. The study included 120 patients who wore OK lenses over 3 years. 40 patients wore OK lenses continuously during the non-pandemic period. Another 40 patients discontinued orthokeratological treatment for 3 to 6 consecutive months in the third year of non-pandemic period. And another 40 patients wore OK lenses irregularly, on average at least 3 nights per week, in the third year of surveillance, which coincided with the COVID-19 pandemic period. All groups were divided according to the degree of myopia, mild or moderate, age 6-17 years and 17-19 years, and the presence or absence of familial factor. All patients have been examined based on standard methods. Does myopia progress after discontinuation of orthokeratology? The data obtained in the study show that in the first 2 years of the surveillance, in all study groups, the evolution of the annual gradient of myopia progression was similar, without statistical significant difference. The difference between these two values manifested in the third year of the study. In the group with mild myopia and 7 at 16 years of the age, who applied OK lenses irregularly during the pandemic period, the annual gradient of myopia progression increased statistically significant up to 50%, compared with patients who apply OK continuously in the non-pandemic period, where the progression was on average of 5% on the initial value. Also, in cases of irregular wearing of OK lenses during the pandemic period, the annual gradient of myopia progression increased significantly more in the group with present familial factor. In the group where patients discontinued OK treatment for a continuous period of 3-6 months, the annual gradient of myopia progression increased significantly in the first year of the study, up to 17% from initial data. In the group with the moderate myopia and 7-16 years of the age, the evolution of the annual gradient of myopia progression increased up to 12.3%. In group who irregularly applied OK lenses in the pandemic period, compared with patients who applied uninterrupted OK in the non-pandemic period in the third year, was on average of 2.5% of the initial value. In the group where patients discontinued OK treatment for a continuous period of 3-6 months, the annual gradient of myopia progression increased significantly in the third year of the study and averaged 45% of baseline. In both groups with irregular wearing of OK lenses, the annual gradient of myopia progression increased more significantly by patients with present family factor. In the group with mild myopia and 17-19 years, the annual gradient of myopia progression was 3.1% in the group who applied OK lenses irregularly during the pandemic period, compared with 1.8% in the group who applied OK lenses continuously in the non-pandemic period. However, the difference between the groups was statistically insignificant. In group with discontinued OK treatment for 3-6 months, the annual gradient of myopia progression was up to 31.1%, which was significantly higher than in previous groups. Compared to previous group, in the groups with moderate myopia and 17-19 years, the dynamics of the annual gradients of myopia progression was similar during all 3 years of surveillance of the patients who applied the lens continuously in the non-pandemic period and irregularly in the pandemic period. In group who discontinued orthokeratological treatment for 3-6 months, the annual gradient of myopia progression was 17.1%. Analyzing the evolution of annual gradient of myopia progression on the group of patients who wore OK lenses irregularly during the pandemic, the rate of progression of myopia in the first and second year of surveillance was reduced to 16.3% and 6.5% from the initial value, namely. In the third year of the surveillance, which coincided with the pandemic period, when patients applied OK lenses irregularly, this value increased up to 10.1%. Questioning the patients shows a similar level of visual, psychological, and psychological comfort in the groups which applied OK lenses continuously in the non-pandemic period and irregularly in the pandemic period. The results of the study showed that interrupted wearing of OK lenses during the pandemic period leads to an increase in the annual gradient of progression of myopia compared to their regular wearing in the non-pandemic period. This could be due to not only to the irregular wearing of OK lenses, but also due to the prolonged time in front of gadgets and the reduced outdoor time imposed by the self-isolation regime. In the group of patients who discontinued orthokeratological treatment for a period of 6 months, was registered a significant increase of the annual gradient of myopia progression compared to patients who applied OK lens continuously. At the same time, the value of this index constitutes on average 40% of its initial value. The questioning of patients showed a statistically similar satisfaction between the groups of patients who performed uninterrupted orthokeratological treatment during the non-pandemic period and those who applied OK lenses irregularly during the pandemic period. Mostly, this was due to the reducing of the visual needs of patients and self-isolation, especially those related to distance, vision, and psychological comfort determined by sight. In the both pictures, the same person is my patient who wore the OK lenses since his 6 years age till 21 year age. Now he did refractive surgery. So, thank you for your attention. I wish you health and peace. Bye.
Our next speaker, Dovgan Olga.
Topic of my presentation is conjunctivitis and iridocyclitis differential diagnosis. Conjunctivitis. The conjunctiva is a thin, transparent vascular mucous membrane of a non-keratizing squamous epithelium investing the inner lid surfaces and the anterior sclera. It is important in maintaining a suitable environment for the cornea as a defense against infection and trauma. Inflammation of the conjunctiva is known as conjunctivitis and is characterized by dilation of the conjunctival vessels, resulting in hyperemia and edema of the conjunctiva, typically with associated discharge. What are the main causes of conjunctivitis? Conjunctivitis can be divided into infectious and non-infection causes. Non-infection causes include allergic, toxic, such as contact lens solution, and secondary to systemic causes and neoplastic process. Infectious causes includes viral, bacterial, rickettsia, fungus, and parasitic conjunctivitis. How do you get conjunctivitis? Bacterial and viral conjunctivitis can be quite contagious. The most common ways to get the conjunctivitis include direct contact with infected person's bodily fluids, usually through hand-to-eye contact, contaminated fingers, medical instruments, swimming pool water. Spread of the infection from bacteria living in the person's own nose and sinuses. Not cleaning contact lenses properly, using poorly fitting contact lenses or decorative contacts are risks as well. Contact with fomites or oculogenital contact with someone infected. Trauma and immunosuppressed status. How do I know if I'm getting conjunctivitis? Symptoms of conjunctivitis include increased tearing, foreign body sensation or gritty sensation, soreness of the eye, itchiness of the eye, excess mucus or pus, hazy or blurred vision due to mucus or pus, crushing of eyelashes in the morning. Iridocyclitis. Iridocyclitis is an eye condition where the iris, the colored part of the eye, and the ciliary body, muscles and tissues that are involved in focusing the eye are inflamed. These two structures, together with the choroid, form the middle layer of the eye, the uvea. They are found in the front of the eye and the choroid in the back. For this reason, iridocyclitis is also known as anterior uveitis, since it affects the ocular structures located in the anterior part of the eye. Causes of iridocyclitis. Any condition that causes damage or inflammation to the iris or ciliary body can cause iridocyclitis, such as non-differentiated enterouveitis, juvenile idiopathic uveitis, juvenile psoriatic arthritis, juvenile reactive arthritis, juvenile ankylosing spondylitis, rheumatoid arthritis, sarcoidosis, Crohn's disease, Rett syndromes, Kawasaki syndrome, injury, infections, trauma, and foreign body. Symptoms of iridocyclitis includes radiating pain, redness around the iris, discoloration of the iris, photophobia, lacrimation, interference with vision, constricted, sluggish pupil, hypopyon, adhesion between the iris and the lens, and exudatis into the anterior chamber. On this table you can see different symptoms. Viral conjunctivitis includes pain known to mild. Viral conjunctivitis may be unilateral or bilateral. Discharge watery, visual acuity normal, pupil unaffected, and congestion superficial. Bacterial conjunctivitis, pain known to mild. Bacterial conjunctivitis may be unilateral or bilateral process. Discharge purulent, visual acuity normal, pupil unaffected, and congestion superficial. Allergic conjunctivitis, pain known to mild. Allergic conjunctivitis is a bilateral process. Discharge mucoid, visual acuity normal, pupil unaffected, and congestion superficial. Anterior uveitis, pain moderate to severe. It is a unilateral process. Discharge minimally and watery. Visual acuity normal or decreased. Pupil constricted. Poor light response may be distorted, and congestion deep ciliary. Thank you for attention.
And next presentation from Moldova. We are waiting.
Hello everyone. Allow me to share with you a presentation on amniotic membrane transplantation as a surgical solution for the treatment of ocular surface pathology, and to briefly describe our experience in the treatment of corneal ulcers refractory to conventional treatment. The amniotic membrane is a biological material increasingly exploited in the field of regenerative medicine due to its anti-inflammatory, anti-fibrotic, and anti-scarring properties. In ophthalmology, the amniotic membrane transplantation has been used for a long time, but it became really successful only in the last few decades with the development of amniotic membrane processing methods and the improvement of surgical techniques. At the present time, including due to its high availability, the amniotic membrane is positioned as a good alternative for corneal reconstruction in many clinical situations. Although in the appropriate indications and correctly applied, the amniotic membrane can have excellent results, it is a remedy with many limitations. For instance, it does not possess intrinsic antimicrobial properties. The latter can be explained rather by the mechanical barrier that the membrane forms on the ocular surface, but also by the prolonged retention of antibiotics in its stroma, thus preventing infection. The amniotic membrane is also not a source of limbal stem cells. Therefore, its isolated use in cases of severe limbal stem cell deficiency has a reserved prognosis. Additionally, intense inflammatory processes such as Lyell and Stevens-Johnson syndromes negatively influence the longevity of the amniotic membrane on this ocular surface. There are three main techniques by which we apply the amniotic membrane onto the ocular surface. The patch technique consists in using the membrane as a biological and antalgic bandage. It is applied over the entire corneal surface with the epithelium facing the cornea and fixed perilimbally with continuous and discontinuous sutures. A protective contact lens can also be applied on top, which will delay the breakdown of the membrane and thus prolong its positive effects. The inlay technique involves the use of amniotic membrane as a graft, including it in several layers. It is integrated into the cornea and serves as a substrate for epithelial regeneration. The amniotic membrane is sutured with the epithelium facing up at the edges of the corneal defect with discontinuous sutures. In this case, placing the contact lens on top is mandatory. The advantage of the inlay technique over the patch technique is the high efficiency in closing deeper corneal defects. And the main disadvantage is the higher predisposition to the development of opacities and corneal neovascularization. That's why the inlay technique is reserved for deep ulcers and imminent corneal perforations. A third method is the sandwich technique, which consists of combining the two previously described methods, that is, applying a layer of amniotic membrane as a bandage over the fragment of amniotic membrane used as a graft embedded in the cornea. Our study included 37 patients with the diagnosis of corneal ulcer of various etiology, refractory to conventional medical treatment. 57% were men and 43% were women, with an average age of 51 years. The amniotic membrane was obtained under aseptic conditions from fresh placentas of seronegative women and cryopreserved at -80°C. After the necrotic scar material was excised from the injured tissue, the amniotic membrane was applied to the corneal surface with the epithelial face oriented down and sutured to the perikeratic conjunctiva with a continuous nylon thread. After the intervention, patients were examined daily for the first 7 days, then 14 days after discharge and monthly thereafter. Results. The average degradation time of the amniotic membrane on the ocular surface was approximately 14 days. The structural integrity of the cornea was improved in 81% of eyes, with limited benefit only in cases of old eye burns and in patients with the autoimmune pathology. In 73% of patients, an improvement in visual acuity was assessed, mainly in patients with the persistent epithelial defects and superficial traumatic ulcers. Even patients with recent alkali burns and mycotic ulcers had a postoperative improvement of 1 to 2 lines on the Snellen chart. 78% of patients reported subjective improvement in the first days after transplantation. In 13.5% of cases, repeated amniotic membrane transplantation was needed to restore the integrity of the ocular surface. And in 5% of patients with deep stromal defects, tectonic keratoplasty was subsequently performed to prevent corneal perforation. Here is illustrated the clinical case of a patient with corneal ulcer developed as a result of herpetic keratitis. The patient preoperatively presented a paracentral ulcer at 7-9 o'clock accompanied by no vessels. In the second image, we see the local status on day 3 after transplantation and the appearance of the amniotic membrane on the ocular surface. And 3 weeks after the transplant and the complete removal of the amniotic membrane remains, we observe the significant reduction of the corneal defect and the stabilization of the neovascularization. Visual function improved by 2 lines on the Snellen chart. Here is the clinical case of a patient with corneal abscess after sustained mycotic keratitis. After stabilizing the process with amniotic membrane transplant, tectonic epikeratic keratoplasty was performed to prevent corneal perforation. Penetrating keratoplasty was subsequently performed with significant improvement in visual function. And the case of a patient with traumatic corneal ulcer treated with amniotic membrane transplantation by sandwich method to stabilize the deep corneal defect and address the imminence of corneal perforation. The patient subsequently underwent penetrating keratoplasty to resolve the central opacification, but due to intense neovascularization, visual function remained relatively low. In conclusion, we can confidently state that amniotic membrane transplantation can significantly increase the success rate in the treatment of corneal ulcers refractory to conventional treatment, either used alone or in combination with other interventions. The satisfactory postoperative results of the transplantation depends not only on the severity of and extent of the corneal lesion, but also on the correct choice of the operative technique for the particular clinical situation. To restore corneal integrity in patients with severe stromal thinning and high risk of corneal perforation, it may be necessary to combine the amniotic membrane with other surgical techniques, such as tectonic epikeratoplasty and/or penetrating keratoplasty. And finally, the multiple advantages of the amniotic membrane, such as material availability, low immunogenicity, relatively easy application, and wide range of clinical indications, demonstrate its attractiveness as a method of ocular surface reconstruction. Thank you for your attention.
Thanks our partners, and our next speaker, Shilik Alina.
Dear colleagues, my presentation is about trachoma in Ukraine nowadays. The causative agent of trachoma is Chlamydia trachomatis. The main ways of transmission are direct and indirect, through hands, clothes, secretions. Reservoir and source of infection is a sick person. Incubation period is 5-8 days. There is no specific immunity. Chlamydia trachomatis occupies an intermediate position between viruses and rickettsia. The pathogen can be stored at the temperature of 20 degrees for up to 7 days. In non-chlorinated water, up to 5 days. In lakes, up to 60 hours. It's extremely low immunogenic activity, which is indicated by the high frequency of reinfections and unsatisfactory results of attempts to use vaccines. Trachoma is a disease of the pure states, such as African states, some regions of the Middle East, the Indian subcontinent, Southeast Asia, South America. Trachoma morbidity were non-existent in Europe and Ukraine for a long time, due to the general improvement of living standard and the implementation of preventive measures. World Health Organization classification, trachomatose inflammation follicula with 5 or more follicles of more than 0.5 millimeters on the upper tarsal conjunctiva. Trachomatose inflammation intense with papillary hypertrophy and inflammatory thickness of the upper tarsal conjunctiva, obscuring more than half the deep tarsal vessels. And trachomatose scarring, presence of scarrings in the tarsal conjunctiva. Trachomatose trichiasis, at least one engrossed eyelash touching the globe or evidence of epilation. And corneal opacity. Corneal opacity blurring part of the pupil margin. Macolin's classification, there is 4 stages. Stage 1 with hyperemia of palpebral conjunctiva, immature follicle. Stage 2, appearance of mature follicle and papilla, progressive corneal panus. Stage 3, scarring of palpebral conjunctiva, scars are easily visible as white bands. And stage 4, disease is clinically cured, scarring's completion. Clinical case, girl, 12 years old, with complaints of lacrimation, photophobia, and redness of both eyes. Disease started in July 2020 after swimming in the local lake. Herpes virus infection of both eyes were diagnosed in regional medical center. Patient received antibacterial and antiviral treatment without positive dynamic. Visual acuity right eye 0.85 and visual acuity left eye 0.5, not corrected. Both eyes clinically blepharospasm, photophobia, logophthalmos, marginal edge thickness, cicatricial changes of the upper eyelid conjunctiva with yellow-pink grains of the trachomatose type. Limbus total neovascularization with vessels and growth in the corneal lower part up to its center. Corneal edema with total superficial staining. All signs are more pronounced in the left eye. Anterior chamber of medium depth, aqueous humor, and deep optical media are transparent. Eye fundus was poorly visible because of corneal changes. No pathology were detected. Laboratory diagnostics include slight increasing in titers of immunoglobulin G to herpes group viruses, and scrapings from the conjunctiva of eyes revealed Provacek's bodies intracellularly. Cultural method, bacteriological examination of a smear from the conjunctiva showed the growth of Staphylococcus epidermidis. Was diagnosed both eye stage 3 trachoma, blepharitis, keratoconjunctivitis, trachomatose panus of the cornea. A specific antibacterial therapy included systemic azithromycin, instillations of 1.5% azithromycin, tetracycline ointment, and parabulba injections of amikacin. Also was made massage of the eyelids with the removal of trachomatose grains by extraction. After reducing of signs of inflammation, resorptive therapy was added. Results. Both sides, the condition of the eyelids has improved significantly. There are no signs of inflammation, deformation and shortening of the tarsus of the upper eyelids, due to which a small logophthalmos of 1 to 2 millimeters was preserved. The conjunctiva of the upper eyelid has cicatricial changes. There are no follicles. The eyes are non-injected, slight residual neovascularization of the limbus in the lower part. The central opacifications of the cornea on the left eye significantly resolved. Eye fundus without pathology. Visual acuity right eye 85% not corrected, visual acuity left eye 70% not corrected. During the control laboratory examination, Provacek's bodies were not detected intracellularly, which indicates the elimination of the causative agent and suppression of the active infectious process. In conclusion, the first appearance of trachoma in Ukraine nowadays should alert ophthalmologists and indicates that the causative agent of trachoma can easily move from one epidemic area to non-epidemic areas due to population, migration, and hygienic rules and conditions worsening. Diagnosis of trachoma is based on the clinical picture, cytological examination of scarpings from the conjunctiva. Intracellular detection of Provacek's bodies remains the golden standard of diagnosis. Thank you for attention.
Inviting our colleagues from Moldova, we are waiting.
Hello everyone, my name is Doina Bobescu and I'm going to tell you about inflammatory glaucoma. Inflammatory or uveitic glaucoma is one of the most serious complications of intraocular inflammation, being secondary to it. Intraocular inflammation leads to persistent or periodical IOP elevation associated with some anatomical and pathophysiological changes specific for open-angle glaucoma. This type of glaucoma is a secondary one and a serious consequence in patients with uveitis caused by systemic diseases, leading to a drastic decrease in visual acuity and invalidation of young, able-bodied patients. It is about 24–40% in the structure of glaucomatous pathology. Worldwide, the prevalence of uveitis is variable from 38 to 730 people per 100,000. In US, its prevalence is estimated to 115 for 100,000 people. About 20% of those uveitis develop inflammatory glaucoma. It's necessary to pay attention to the following. The terms inflammatory glaucoma and or uveitic glaucoma should be used with caution and not assigned to every patient who has uveitis with increased IOP. In case of intraocular hypertension in uveitic eyes that do not have glaucomatous optic nerve head and or perimetric changes, the following term will be used with preference: intraocular hypertension related to uveitis, ocular hypertension secondary to uveitis, or secondary ocular hypertension. We can talk about an inflammatory glaucoma only if we establish that the patient suffered or suffers from uveitis, has increased IOP, has glaucomatous optic nerve head and or perimetric lesions, and did not suffer from glaucoma before the development of uveitis in the affected eye. In inflammatory glaucoma, optic nerve head damage occurs due to elevated IOP. Thus, in the absence of prior data of the increased IOP level, the diagnosis of glaucoma related to uveitis, inflammatory glaucoma, glaucoma secondary to uveitis, will be established very carefully. Also, the diagnosis of inflammatory glaucoma should be approached with caution in patients with visual field lesions uncharacteristic of glaucoma and normal optic disc status. This is primarily due to the fact that in many forms of uveitis, especially affecting the posterior segment of the eye, chorioretinal foci and damage to the optic nerve result in the development of visual field defects which are not characteristic for glaucoma. Also, it's important to make a differential diagnosis between visual field disorders because if they are caused by an active inflammatory process following appropriate therapy, they can regress or even disappear, while glaucomatous visual field changes are irreversible. Uveitis incidence is about 17 to 52 per 100,000 persons. Its prevalence is from 38 to 714. They can start at any age, but are more common between 20 and 59 years old. About 35% of uveitis patients suffer from serious complication of the disease. Causes of visual loss in patients with uveitis are secondary glaucoma, cystoid macular edema, cataract, ocular hypotony, retinal detachment, subretinal neovascularization or fibrosis, optic nerve atrophy. Anterior segment inflammation can directly affect the aqueous humor drainage pathways, thus increasing IOP and developing glaucoma as a complication of anterior uveitis or panuveitis. About 25% of patients with uveitis have increased IOP and 20% have inflammatory glaucoma. Unfortunately, the treatment of uveitis with glucocorticoids contributes, along with other pathogenetic pathways, to the increase of IOP and irreversible changes in the structures of anterior chamber, anterior peripheral and posterior synechia, which can close the iridocorneal angle, lead to severe glaucoma resistant to all therapy drug. The mechanism by which inflammation increases IOP is not yet fully elucidated, and the pathogenetic pathway remains shrouded in mystery. Uveitic glaucoma boils down to a complex of interactions, and the open iridocorneal angle aqueous humor formation and evacuation response to corticosteroids are at the forefront of this. At the basis of the appearance of inflammatory glaucoma is the imbalance between the formation and the evacuation of aqueous humor due to inflammation, which leads to an increase in IOP. Even though in episodes of intraocular inflammation, IOP usually decreases due to hyposecretion of aqueous humor secondary to inflammation of the ciliary body, in episodes of uveitis, there are multiple mechanisms that conspire and lead to an increase in resistance to outflow of aqueous humor, which leads to a subsequent increase in IOP. Among these mechanisms are the following. First one is pupillary block. Due to pupillary seclusion in uveitis, the iris bulges and the pupil is blocked. The second one, angle closure without pupillary block, peripheral anterior synechia in chronic uveitis, fibrovascular membranes in chronic uveitis, and less commonly, non-pupillary angle closure glaucoma, which develops when inflammation and edema in the acute episodes of uveitis causes vascular body to rotate forward and block the angle, mechanism described in patient with Voigt-Koyanagi-Harada syndrome. And the third one, but not the last, excess of acute uveitis, obstruction of a trabecular meshwork with inflammation, inflammatory cells, proteins, debris, fibrin, dysfunction of trabecular lamella, rhokinase mediators, which constrict the trabecular endothelium. Here are some images with secondary angle closure with pupillary block, iris bombi, iridocorneal contact. Here is our patient with posterior synechia with pupillary seclusion and iris bombi in a patient with chronic relapsing uveitis. Chronic uveitis, severe clinical form of infectious etiology, AIDS, cytomegalovirus, herpes simplex virus, and stage inflammatory glaucoma in both eyes, with anterior synechia, which closes the iridocorneal angle, and seclusion, pupillary occlusion, and anterior synechia in the next image. Steroids are one of the most commonly prescribed drugs used mainly in the treatment of various autoimmune and inflammatory conditions. Although it has numerous benefits, steroid usage can cause many adverse effects on the eye, the most important being steroid-induced glaucoma and cataract. Steroid-induced iatrogenic glaucoma was described for the first time in 1950 with the observation of glaucoma following the use of systemic adrenocorticotropic hormones and topical or systemic steroids. Chronic intraocular inflammation leads to increased production of inflammatory cytokines such as interleukin beta and interleukin 6, which are induced to the production of VEGF by Müller cells, which in turn act through a protein-mediated cascade kinase C. Anti-VEGF has limited anti-inflammatory action and therefore may be useful in the presence of macular edema and active intraocular inflammation. So, inflammatory glaucoma is a plurietiological pathology that requires a careful and multidisciplinary diagnosis and therapeutic approach to obtain adequate control of intraocular pressure and inflammation. The development of inflammatory glaucoma occurs as a result of the intersection of several pathogenic pathways that act synergically and complicate the therapeutic possibilities of a clinician. Each patient, each case must be analyzed separately. Each condition should be reassessed several times and, if necessary, resume the etiopathogenetic treatment. Thank you all for your attention.
Thanks our foreign colleagues, and next speaker, Drumi Dmitry.
Now let's talk about Graves' disease. Graves' disease is an eye disease associated with disease of the thyroid gland. Most commonly, it occurs with an overactive thyroid toxicosis. It also occurs in hypothyroidism, for example, with Hashimoto's disease. This slide shows risk factors, which include family history, sex, age, other autoimmune disorders, emotional or physical stress, pregnancy, and smoking. Pathogenesis or pathogenesis of Graves' disease consists of increase in muscles volume due to cellular infiltration, swelling of the soft tissues of the orbit as a result of excessive accumulation of gags, and increase in the volume of orbital fat against the background of impaired adipogenesis. Diagnostic include complaints, anamnesis, thyroid status, T3, T4, TSH, antibodies to TSH, and peroxidase. Thyroid ultrasound, study of acuity and visual fields, exophthalmometry, study of the mobility of eyeballs, fundus examination, measurement of intraocular pressure, ultrasound of orbits, and CT and MRI of the orbit. On this slide you can see CT scans that show enlarged muscles of the eye. Now talk about Graves' disease treatment algorithm, which consists of normalization of thyroid function, pathogenetic therapy, medical therapy, radiation therapy, surgical treatment, physiotherapy treatment, and extracorporeal hemocorrection. Now talk about treatment. Treatment consists of radiation therapy, X-ray therapy or telegamma therapy on the area of the orbit. Physiotherapy consists of electrophoresis, magnetotherapy, electrostimulation of the levator and extraocular muscles, and extracorporeal hemocorrection, which include plasmapheresis and hemosorption. Surgery. Surgery consists of eyelid surgery, surgery on muscles, and orbital surgery. Eyelid surgery consists of temporary or permanent blepharophia, levator tenotomy to eliminate lagophthalmos. Surgery on muscle consists recession or resection rectus muscles of the eye to correct diplopia and eliminate strabismus. And orbital surgery consists of orbital decompression. Prevention of Graves' disease consists of early detection of the disease, elimination of risk factors, and prevention of disease progression and complication. That's all of Graves' disease. Thank you.
Thanks a lot, very interesting presentation. We are very appreciate our partners for holding this new conference, and I hope it's not the last. And I would like to thank our brave guys who protect us, protect Ukraine, and we have opportunity to hold this conference. See you next time. Thanks.
Ми живемо у прекрасному світі, але деякі люди його не бачать. 253 мільйони людей страждають на порушення зору, та 36 мільйонів людей сліпі або втрачають зір. Але зараз 80% усіх порушень зору можна запобігти, вилікувати чи відновити. Останні 150 років ми були новаторами в офтальмології. Ми розробляємо методи лікування, забезпечуємо інформацією та ділимось знаннями з фахівцями по всьому світу. Наша місія полягає в тому, щоб дати можливість усім дивитись на світ широко розкритими очима. Давайте відкриємо свої очі. Let's open our eyes.